It's a big topic, and I think the way I like to break any healthcare intervention down is actually to make it simple. And this is really important when it comes to recruiting patients into clinical trials. And it doesn't matter what the trial is. Essentially, the important thing to understand is equipoise, the balance between the different treatment arms that you have. And I had a bit of a kind of, a revelationary moment a year or two ago when I started thinking, actually, when it comes to interventions, it is just a balance of risks and benefits. The risks are easy to define according to the type of treatment that you're giving in each treatment arm, but when it comes to the sort of the benefits, it is about quality and length of life. And an understanding of quality of life has been lacking in many clinical studies, and for example, the big studies of different modalities in stage 3 lung cancer didn't really provide robust quality of life data. That's something that's very important. But when it comes to early stage disease, we are also getting smarter, and we need to know more about the quality of life in the kind of the latest surgical techniques. We're very lucky in Sheffield to have appointed 2 extremely good Italian surgeons that came to us and brought good techniques and actually made us do those techniques. And Lara Socci in particular brought the technique of single port video-assisted thoracoscopic surgery, so it's a mouthful even for me, single port VATS, which means the traditional thoracoscopic approach has been, we've seen that increasing through the national audit fairly substantially in the last sort of 10-15 years. But that tends to rely on 3 ports of 2 centimetres with 1 slightly longer for the utility port to remove the sample. And that still provides a fair amount of interaction with the chest wall. You know yourself that if you poke yourself in the ribs, it hurts. Why is that a phrase? Because poke somebody in the ribs, it hurts. You just do that enough times, you realise it's not pleasant. So what we can do is to try and minimise the impact on the chest wall, and hopefully that will translate to better quality of life. So by doing things through one hole and using the enhanced recovery after surgery program as well, and special pain protocols, we're able then to start to do things through one hole of between, well, certainly less than 6, sometimes 3 or 4 centimetres in length. And if you are as talented as my colleagues, you find that you can do whatever you want through that incision, be it even a sleeve resection. For normal surgeons like me, you can still perform a very nice lobectomy or a segmentectomy through single port VATS. And this is something that we've been doing in increasing numbers since 2013. And we've now found a rapid increase in the uptake of our single port VATS program in that time. So we're now performing about 75% of all our lung cancer resections through single port VATS. And we thought actually it's time to present some results. So we've probably got about 600-700 cases that we've done now. And so what we've been doing over the last 6 months, and will continue for as long as it takes, is to start analysing those outcomes in as intense way as we can. So we have some young research fellows who are looking at a number of different factors, one of them being a prospective quality of life study. So we're measuring the quality of life at multiple time points to chart the recovery after single port VATS compared to thoracotomy, because that's our alternative. But we hope that we'll be able to use those data against the data in the literature to determine where single port VATS may lie in terms of a quality of life trajectory. The other parts that's important to ensure is that the quality of that surgical approach is the same as a thoracotomy or the same as a multi-port VATS. So another large aspect is that we're looking in great detail at the histopathology reports of maybe 2,500 cases to assess as highly as we can the degree of quality of the surgery that's been performed. So again, we have another young research fellow who's going through those reports at the moment, and then we'll be looking to ensure and check to see whether the quality of surgery is the same. And that will then lead into other studies and looking at other aspects, looking at how quick we can get to adjuvant chemotherapy if we need to, seeing where the ability to provide the single port VATS lies compared to a thoracotomy, and just try and understand exactly where we lie. But it's strange. I mean, we've found that we have managed to adopt it, and surgeons I literally changed overnight from going from 3 ports to 1. And have not found it to be as challenging an issue as I thought. Yes, the instrumentation is important, and with the correct instruments, we find that it doesn't take a huge leap in technical experience to be able to do that approach. And that's also important because there are other new approaches, and the other one that is attracting a lot of attention is robot. So the so-called RATS, the robot-assisted thoracoscopic surgery, are programs that are existing in a number of units, and for example, St Bartholomew's Hospital, BATS in London, has a large robot program that is now gaining their own data. But the issue there is that the technology is kind of actually behind the human at the moment. What they can do is very good, but they do require a number of different ports. And I guess where we would like to be is to develop into the single port robot, and that is something that industry are beginning to develop, and we hope that we will have opportunities to change from hands to a robot through the single port in the coming years.